It's going to be about abnormal platelet counts. So going over some abnormal platelet counts. And again, I'm one of the pediatric hematologist oncologists here at Kopiolani. So we'll go over some causes, diagnosis, and how to care for these patients. So I have no financial conflicts to disclose. Alrighty, so our objectives for today, and apologies if it came across as other ones, but the objectives, primary objectives today will be to classify and identify common causes of both thrombocytopenia and thrombocytosis in children, to then apply a systematic diagnostic approach to abnormal platelet counts, and then to outline some management strategies for patients with abnormal platelet counts. All right, so first and foremost is to define the abnormal platelet count. Oftentimes we will hear about people who are or providers who might be concerned because they, first of all, flag abnormal on a lab slip, but just to know, like, it's not always abnormal, first and foremost. So just because it flags abnormal, it might not actually be abnormal. In general, it's between 150,000 and 450,000. There's a little bit gray. It's not black and white all the time. There is a peak in like infancy, the neonatal and infancy period, but essentially 150 to 450 more or less. And then it can be categorized similar with neutrophils, neutropenia, like mild, moderate, severe. So thrombocytopenia, 100 to 150 mild, 50 to 100 being moderate, and less than 50 severe. Similarly with thrombocytosis, but a little bit broader, 450 to 700, 700 to a million, and then over a million would be like your extreme. And again, this can vary based on patients' ages. And then there is a general decline a little bit in adolescence, but again, about 150 is what we say is the cutoff for thrombocytopenia. All right, so thrombocytopenia, first and foremost, this is very common in neonates, and we'll go through this a little bit, but very common. So 5 to 15% of neonates will have thrombocytopenia at some point. Thrombocytosis is common in general in the pediatric population, and this is also for a plethora of reasons. And a lot of times this is going to be an incidental finding, right? You're looking for something else, or you're doing a screening CBC or whatever. And so again, sometimes this is just incidentally found. All right, so mechanisms. So why does thrombocytopenia occur? In general, these different broad categories. First, decreased production. So the bone marrow is not working appropriately. And what could this be related to? A plethora of reasons, whether it's a bone marrow failure problem. So it could be something that's either inherited or acquired, as well as things like viral suppression, medications. And again, we'll get into more detail. Increased destruction or consumption. So when, again, if you have hemolysis, hemolytic conditions, or consumption, whether it's into clots or the spleen, clots, and then sequestration, such as into the spleen or other. So more specifics on decreased production. So again, bone marrow failure conditions, suppression and infiltration. So infiltration being your things like leukemia, or if you have a condition where it's basically plugging up the bone marrow and leading to decreased production. Some congenital platelet disorders that we might see that can lead to thrombocytopenia, Fanconi anemia, Wiskott-Aldrich, congenital amegakaryocytic thrombocytopenia, some of the ones. Again, these are quite rare, but it is on the differential for thrombocytopenia. Nutritional deficiencies, so a variety of nutritional deficiencies, infections, things like viruses, funguses. CMV is a classic virus that we see causing thrombocytopenia, not only in neonates, but can also be, for example, in our immunocompromised patients. And then different medications, things like anti-epileptic drugs, heparins, of course, antibiotics, things like your penicillins. Another etiology or broad category for etiologies, increased destruction or consumption. So a lot of these are your three-letter conditions is a way to kind of remember this, but ITP, immune thrombocytopenia, I'll get into more detail because this is something that is quite actually common. Neonatal auto and alloimmune thrombocytopenia, so your NAIT, patient with NAIT, the neonatal alloimmune, thrombotic microangiopathy, so DIC, TTP, hemolytic uremic syndrome, HLH, so patients who present with fevers frequently will have these cytopenias as one of the diagnostic criteria that you could see in HLH. Heparin-induced thrombocytopenia, not common in pediatrics, but we have definitely seen this, and it does exist. And then thromboses. So this is part of that consumption part. If someone's having a clot, platelets like to go to areas of thrombus. And then sequestration. So patients who have hypersplenism, for example, you can see this. So a classic example, we don't see a lot of this here, but in different parts of the country and the world, sickle cell anemia, if patients have sequestrations, they can also actually consume the platelets. And then, of course, is always pseudo-thrombocytopenia. So patients who have where it clots in the actual tube. So typically, it's collected in an EDTA tube. And so first and foremost is this actually real thrombocytopenia? And so this can actually be collected in other tubes where that wouldn't happen. Also rare, but it does exist. And then delusional. So some common causes by age. So neonates. So this can be categorized as kind of time dependent wise. So if this is an early, right after birth kind of situation, or we would say later, so after 72 hours. So when they're older, typically it's going to be related to infection or sepsis. These kids will be sicker. And then when it's earlier, things like placental insufficiency, intrauterine growth restriction, congenital infections, back again to CMV is a classic. And then your neonatal alloimmune thrombocytopenia. This typically would be, well, and I'll get into more detail on this one too. Can be very severely low, and is typically seen in our healthy babies, and it can persist. So yes, we see it less than 72 hours, but it can go beyond the 72, as essentially all of these can, but it's when they present. And then children, again, ITP, medications, kind of some of the ones we just talked about, viral, and then leukemia, and adolescents, ITP, autoimmune, also malignancy, of course, medications, and sometimes substances. All right, so ITP. So this is the most common acquired cause that we would see in children. It's immune mediated, and there is thought that there's some sequestration, splenic sequestration, but it doesn't mean that they're going to present with splenomegaly, and the actual mechanism is not totally understood, but an autoimmune process. It's a diagnosis of exclusion. So you're looking for all these other things that could be causing the thrombocytopenia before you essentially deem it for sure ITP. There's fairly classic history and physicals, and then also looking at the peripheral smear. So these patients, you'll see basically no platelets sometimes, but when you find them, they're huge. And that's really exciting because it's more or less slam dunk diagnostic for these patients because it's these baby platelets. The bone marrow is still working, but the platelets are being destroyed and consumed. So it's not a bone marrow problem. So they're pumping out these big baby platelets. And they're very pretty and fun to look at. Okay, and so then in the neonates, neonatal alloimmune thrombocytopenia. So this is similar to our RH disease of the newborn, but essentially it's with the platelets, and it can happen in your first pregnancies. Whereas RH, right, much less, almost never, unless you've been exposed previously. But this can occur in the first pregnancy. This is when the maternal antibodies go and basically are against the fetal platelet antigens, these HPA different antigens, and their HPA1 is 1A and 1B, but ultimately it's the mom antibody against the baby platelets. This is important to recognize because this can cause severe intracranial hemorrhages, including in these first babies, and it can be worse in subsequent pregnancies. Excuse me. To confirm diagnosis is doing platelet antigen typing on the baby and then maternal antibody testing, or you can do platelet antigen testing on mom and dad. And then you would see differences. And then also with the mother having antibodies against the mismatched platelet antigen on the dad. Trouble with this is like not going to happen today, right? So you need to be treating baby for this because this takes, I don't know, days, weeks, and oftentimes truly it's not always even done. So it's just having high alert that this is something that exists and is important to recognize. ideally you want, and that shouldn't say HPA, say HPA, I'm sorry, compatible platelets. But that's also often hard to find, but that's the best. And then also giving actually mom's platelets to baby is amazing, but also very unlikely to actually be a reality. But compatible platelets for baby, and then IVIG, when this is known for mom, can be given throughout the pregnancy. And that often prevents this entity from happening, plus or minus steroids, again, to the mom, and then also to the baby. Okay. And we'll come back to like going back and forth a little bit, but now thrombocytosis in pediatrics. So secondary, it's almost always going to be a secondary process in pediatric population. Very rarely is it primary in this population. That's much more common in the adults. So secondary or reactive thrombocytosis. This can be due to a plethora of things. Again, it's very uncommon that we get super excited about thrombocytosis because it's just frequent that we see it with so many different things. So infections, anytime you're in an inflammatory state, these are acute, like kind of like acute phase reactants. So they go up in settings of inflammation. Iron deficiency anemia, we see a lot of this too. Similar reactive process. Injury, post-splenectomy, you can have a reactive thrombocytosis with post-splenectomy. Rebound after myelosuppression. So we also see this in some of our kiddos when we give intensive chemotherapy or other cytotoxic drugs, and then their bone marrow will just rebound, and then they go beyond the 450,000. And then medications can also sometimes do this. So primary, again, is very rare, but could happen. One, essential thrombocythemia, so or ET. So this is something that is an acquired prothrombotic situation that could lead to excessive thrombus. So if there's a significant strong family history of clots, then this could be something in the patient. But without any family history, again, very, very rare. Polycythemia vera, also very uncommon in kids. It does exist, but I think there's like one every few years that we see in the clinic. Myelofibrosis, again, this is much more likely in adults. And one thing that I would say is that we do see with thrombocytosis is CML. So we do have patients who have presented with who have CML who also have thrombocytosis. So this is one of those situations to be on the look. Not always on the lookout, but to be aware of. So if someone has a mildly elevated white count and thrombocytosis, could just something on the radar, or splenomegaly with thrombocytosis, just as an example. So this is one thing that I would say that we do see on occasion when our patients present with CML. You do not have to have thrombocytosis to have CML. Like that is not part of the diagnostic criteria, but it can happen. Okay, so now working these patients up, right? So when your patient comes and has thrombocytopenia, first and foremost, one is verify, right? So is this real, or is this pseudothrombocytopenia, for example? Or if it just seems weird, right? If someone looks totally fine, they have zero bruising, bleeding symptoms, and their platelet counts back as 7, that doesn't seem to make sense. So one is you can look at the peripheral smear, right? Or ask someone to look at the peripheral smear. Sometimes these can clump along what's called the feather edge. When they make a smear, they can clump, and they can actually see platelet clumping, but they're not always going to report this on the lab values. But it's something you could ask them to look for. The other thing is again, I touched on EDTA collection. So some people, rare, but some people will clot in an EDTA tube. So then you can ask to have it redrawn in either a heparin tube or a citrate tube. And that should give you a more accurate value. So again, verify if you're ever unsure. Second is to know history and physical, right? So is this an acute process? They've been having increased bleeding for 7 days, or you know what, I've been having some nosebleeds on and off for the past 4 months, kind of a thing. So just getting a good history, a good part of the history is trying to recognize if this is an acute or maybe a more chronic process. And asking about, again, bleeding signs and symptoms. What medications are they taking? Have these patients been recently ill, had any virus type of prodrome, and any recent immunizations? And then on your physical, right? Looking for concerning also signs such as lymphadenopathy, hepatosplenomegaly. Do they have petechia? Do they have purpura in their mouth? Things like that. And then your laboratory evaluation. So with that, you're going to get a CBC with differential, right? Is this single isolated thrombocytopenia? Is it pancytopenia? Is there an elevated white count? Is it anemia of thrombocytopenia? So you want a complete CBC. Looking at the peripheral blood smear, this can often be really helpful. And so when we look at a peripheral blood smear, we typically would want to start with the cells we think we don't really care about. Like, so do the white cells, do they look normal, or are there some that look concerning for potentially blasts? As an example, the red cells, is there evidence of a lot of schistocytes, right? Does it look like this hemolytic process? Platelets, are they small? Are they large? Are they clumped? So looking at the blood smear can actually give you a lot of information. Coagulation panel, and this is not like a mass, every child needs all of these things, but some things to think about based on the history and physical for the patient. So your coagulation panel, right, if you're concerned about TTP or HUS, but getting PT, PTT, fibrinogen, just to see if there's evidence of like one of those processes happening. Hemolysis lab, so LDH, reticulocyte count, bilirubin, helpful as well to see if there's a hemolytic process contributing. And then other things like viruses, and then ultimately, if this is either not conclusive or you're concerned enough, a bone marrow evaluation might be warranted. And then thrombocytosis. So verifying, typically not necessary, right? If you have reason to support why a patient might have thrombocytosis, you don't typically need to repeat it, at least not right away, to verify this. Really what you're going to do almost always is search for an underlying cause, because again, this is presumably going to be reactive. So for management, just a few things for some of these specific entities I started to talk to you about. So ITP. So again, ITP, very common. Fortunately, most of these patients will recover on their own over time. So if you have a confident diagnosis of ITP, not always, but a lot of the time, I would say the majority of the time, vast majority of the time, you can actually closely monitor them without further medications. We tell families, depending on the situation, and this can vary based on age and of course symptoms, but by 3 months, 6 months, and then a year, typically most patients have recovered by 6 months. Sometimes it takes longer. But again, most of these patients will recover on their own, but it is very anxiety provoking sometimes for not only families, but can also be for the provider too, right? Because it's this watch and wait and just ensuring that they do improve. So though that time that can be appropriate when patients look really well, they don't have any significant bleeding symptoms, and we know you have good follow-up with the families and things. Other things that can be used, steroids. Historically, and at some places, and sometimes personally, treating with steroids, even though you feel comfortable and confident in your diagnosis of ITP, we do know one of your differentials for thrombocytopenia, right, is leukemia. And we know that steroids treat leukemia. So it's not that you can't start steroids in a patient who has ITP without a bone marrow, but you just want to be real, totally certain that you are treating ITP before starting steroids in an ideal setting. And the reasoning for that is because again, if it's leukemia, then you're starting to treat leukemia, and that would change things going forward. But ultimately, steroids, very effective, very cheap, can be done outpatient, work really well. And the vast majority of patients will respond quickly. It does not, none of these medications, by the way, change the cure of ITP, but they treat they treat the number and basically get the platelet count up faster and can keep them up. But the ultimate underlying disease process is going to be what it is. So they're not cures per se, but they treat the process until the patient has recovered, if they do recover. So steroids, IVIG, also very effective, can work faster than steroids, but expensive. You can have All of these have different reactions. We have to get an approval if we do it outpatient, right? Because again, it's expensive. And then anti-D or RhoGAM, essentially more RhoGAM-ish, right? If you have the Rh antibody, if you're like O positive, A positive, you do have to check the blood type. This can also be very effective. Kind of similarly, side effects, fever, chills, back pain, things like that. So not everyone loves using this. This is actually not a commonly used one, but it is something that is available and can work. More in the front line are these thrombopoietin agonists that stimulate the bone marrow to pump out platelets. These can also be really effective, and these used to be used more isolatedly in chronic ITP or patients who go on to have this long term, but it's actually being used more in the front line too. This comes in multiple varieties, which is nice, and there are multiple of them. And also, patients respond nicely to this as well. It takes a little bit longer to respond, but they do work and they're effective. They come in PO and sub-Q. The sub-Q is weekly dosing, oral is daily typically. And you would tweak the dose based on their response. So if they have a robust response and go way too high, then you drop dose. So you do have to monitor with this. And also when you wean them off, sometimes they will drop back down. So again, it just kind of depends on the situation. Falling lower on the list are other things like rituximab. So this is your CD20 right, targeting agent. So it's basically depleting the B cells, which are making these antibodies that are attacking the platelets. But again, one of the further down the line medications that we would use. And then CellCept. And then really, I haven't seen this done, I don't think at all since I've been here for ITP, splenectomy. So this was something that used to be done. And if, really there's nothing that's working and it's a true problem, splenectomy could work. But again, it doesn't always. So a lot of caution with that. And then thrombocytosis. Again, this is, most likely going to be reactive. And so you want to treat whatever the underlying cause is. And most of the time for these patients, even if it's extreme, over 1 million, typically there's no routine use of prophylaxis, things like aspirin, that are absolutely indicated or necessary. So when to transfuse in patients with thrombocytopenia. So this is very variable. There's not a ton of randomized trials, but one that was pretty cool that was done in the published in the New England Journal of Medicine. I think I have this at the end of on one of my references. They actually compared these premature neonates to less than 25 versus less than 50. And what they found was there was actually decreased morbidity when patients were transfused at the less than 25 compared to less than 50 without increased risks of major bleeding. So it's actually recommended to transfuse at a lower threshold, unless, of course, there's another clinical indication a baby is actively bleeding. So these would be healthy premature neonates. Caveat to premature, and I have it on my notes, but I think it was greater than, I want to say 34 weeks. So this is not in the case of all neonates. And I can get back to you if that is a question, but I think it was 34 weeks and above, but I can double check. But that's really nice because it saves transfusions, it saves a lot of potential adverse effects that can go along with this, and saves product, which is always great. For our patients with hypoproliferative thrombocytopenia, so this is like our population when we're giving chemotherapy or they go through transplant. If they're not bleeding, we typically keep them above 10. And it's debatable whether you wait till they're 7 and then you transfuse, or they're down at 12 and then you transfuse to keep them above 10. But generally, our goal is over 10,000 in these patients. For patients who are getting lumbar punctures, generally you want them over 20,000. And then for major non-neuraxial surgeries, over 50,000. And always providing thrombocytopenic precautions. So they do need activity restrictions depending on the clinical the clinical condition and their platelet count. It is going to be different, a little bit different based on like if you're getting chemo and you have low platelet counts versus you have ITP. And your patient's also going to be very different, right? Many of you who've maybe seen patients with ITP, they're typically very active, right? They want to like ride horse. I remember riding horses or whatever thing that can cause head injury. So the extreme sports you want to caution them on, and always that, of course, when you have your patients who are getting chemo or for those other reasons. But you do want to limit their intense activity when they're particularly like less than 10, 20, 30,000. When they're higher, they can have less restrictions, but just to use caution. Avoiding NSAIDs and other antiplatelet agents because these can affect platelet function. So they don't decrease the count, but they can affect how platelets work. Aspirin, of course, has a very long half-life. Your Motrin, ibuprofen, if they need a spot dose here or there, depending on the count, it's not always an absolute no. It just depends, again, on the clinical condition. But definitely aspirins in our kids we avoid anyways, right? Almost always, depending. Almost always, but yeah, avoiding those when you can. And then just making sure they're well educated on what to be looking for, things that would warrant urgent evaluation. Of course, again, any head trauma, if they're in any accident, if they're acting strange, if they're having this prolonged or heavy bleeding, that's not stopping with pressure or becomes excessively long. And when should you refer? So the asterisk is, again, this is general, and you are always welcome to call and reach out and email with whatever, right? But in general, if they're less than 20, for sure, right? Like, why are they less than 20? Could be ITP. Sometimes we can just discuss and monitor together. But again, if you're ever concerned, just call. If patients have thrombocytopenia in association with bleeding, of course, if you're concerned about malignancy or an inherited disorder, or if patients have pancytopenia, bicytopenia, and then in the NICU, of course, if there's any concern for NAIT, among other reasons. And then thrombocytosis. So much less commonly you need us. Persistence, though, without any identifiable cause could be cause for concern, right? If someone's constantly above 1 million and are otherwise well, that really shouldn't be a thing, right? You have to have some underlying reason for why that's happening. Again, suspecting either a malignancy like CML and or if it's associated with any kind of thrombotic or hemorrhagic complication. So some take-home points. First and foremost, just always verifying, right? And like, is it actually abnormal? It's not just what's on the piece of paper, but it's also like, again, that range. And there's different labs, different places that will see their ranges 210 to 400. And it's like, no, actually it can be a little lower, a little higher than that. And then again, just checking like, does this number fit with my patient, right? There's no bruising, there's nothing concerning. So either poke them again or look at the smear or maybe draw it in a different tube. ITP is going to be the most common acquired cause for our pediatric patients, but again, it is a diagnosis of exclusion. So you want to make sure that you've ruled out other things before you just say it's ITP. NAIT, leading cause of severe thrombocytopenia in our healthy babies. And again, this is associated with a very significant risk of bleeding. And so it's just good to be cognizant that this entity exists. Reactive thrombocytosis, much more common than secondary in our patients. The recommended use of restricted platelet counts in our premature neonates. So again, the less than 25 compared to 50. The importance of the peripheral smear and how important it could be. And then just knowing again what you can always refer whenever you're worried ultimately. So I have questions. I don't know if you're gonna do I run through these or do you guys run through these?
We'll pull them up so
Okay.
that everyone can answer them. And
Okay.
then once everyone's had a couple minutes to answer them, we can go through your correct answers.
Sounds good. Thank you.
Thank you. I learned a lot already in a very short time period. That was really
That's kind of
interesting.
you.
Thank you so much.
Whenever you want. One more time, so you'll tell me, right? I don't. I just don't want
Yeah.
to. Okay,
No,
cool.
you're good.
Okay, great. Okay.
Since we have time, we can give everyone
Yep. Okay,
another
sounds good.
minute or two.
Sounds good.
I know I'm very bad about just sitting quiet
No, sorry,
during this
sorry.
time too. I want to like sing the Jeopardy song or something. I also realized that I had left my audio on, and I don't know if you guys can hear the roosters in the background, but it felt like a very Hawaiian moment. I was just like, oh my gosh,
I
they're
just saw a
having a
big smile on
party.
your face, so I assumed that that was
I
fun.
thought those were roosters in my in my background.
They could be in anyone's background, really. See, maybe if once we hit 50% participants or something like that, we can move on. We're almost there, guys. I appreciate the like very like case-based questions though. Those are always good.
Thanks.
Okay. Shall we go through questions? Okay. It's all
Oh,
yours, Dr.
oh
Hutchins.
no, that's not what I meant to do. Anyways, sorry.
No, you're good.
I don't know how to go back.
Um,
Can I go back? I think every time I click it, it goes forward.
if
Uh,
you exit the full screen, you might be able to see it.
let's see. Hmm.
Or
Oh,
there on the bottom. Um,
oh, okay,
oh,
okay, no, yeah. On the bottom.
I feel like I saw it pop up on the bottom left of your screen.
This,
There.
oh, hello. Thank you so
Yeah.
much. Oh,
No,
yes.
you're good.
Oh,
There you
sorry,
go.
this is not my forte, but okay. So our first
Good.
question, you have a 4-year-old male who comes to you with mom noticed these diffuse red spots on his neck, arms, and legs. She said they've been there for, she thinks, 2 days, and he also is having bruising. She's like, he just seems to be bruising kind of everywhere. Recalls that 2 weeks ago, when you ask, he had a runny nose and a fever, but that's now resolved. He's otherwise super healthy, super active and appears healthy in your clinic. His platelet count when you check a CBC is 6,000. The rest of the CBC is normal. Which of the following should you do? Should you transfuse platelets? Should you perform a bone marrow aspiration and biopsy? Should you provide reassurance and thrombocytopenic precautions and repeat a CBC in a week? Or should you start IVIG? Do you guys give the result? Do you guys do the little poll or no? I just go. I just go. I'll just go. Um, yeah. So you would provide reassurance because this patient has ITP. So he's well appearing. He has a history that He had a virus 2 weeks ago, and now he's presenting to you otherwise looking good without concerning bleeding symptoms, not actively bleeding. Yes, he has petechia and bruising, but that's in and of itself not dangerous. And so it's okay to provide reassurance and provide education and then see them back closely. You do need to ensure that this goes away over time, but that is acceptable for this patient. Move on or take questions? Just move on. Whatever.
I actually have a question.
Yeah.
How frequently or how soon would you be trending CBCs on in an outpatient setting with platelets this low?
Yeah, if it's this low, I would do weekly until it recovers. Some people might feel comfortable doing every couple weeks. And if they're really totally rock stable and you have a reliable family and it's really not doing much, but there's no other concern, I think over time you could space it. I would still probably start with once a week for the first few weeks at least. And again, sometimes you start to see this recovery, sometimes fast, like sometimes you wait a week and it's better. Sometimes it takes a few weeks, few months, and then rarely it doesn't. Yeah.
This would make me very nervous to treat as an outpatient, but I'm obviously also not an outpatient provider. This is not my forte whatsoever.
So it's very interesting because that's interesting though, because I would argue that that is common to feel that way. And where I previously was, it was also different, like just different. And so I think just training and like seeing things for a while, right? It brings different perspectives, but in my prior training place, I think that similar sentiment would have helped, So, but yeah, it's, yeah. And again, it can also vary, right? If you have patients who are in like a real remote place, or this patient, someone has autism and they bang their head, right? Or if like you can't control a patient or you don't have a reliable family. So with those kind of caveats, but in general, you have a reliable family that can come back and forth. This would be the ideal situation for this patient.
That's amazing.
Good question.
Thank
Okay. Yeah. So the next one, so this next patient, so this is another 4-year-old male who comes to you and is having this increased pallor and fatigue and fevers with complaints of leg pain that have been progressing over the past few weeks. In your clinic, patient has a fever of 101.2 and looks just tired and pale. Also has this scattered bruising, and you notice lymphadenopathy and hepatosplenomegaly. You get a CBC, and it's remarkable for a white count of a mild leukocytosis, 18,000, predominantly lymphocytes, a hemoglobin of 7.2, and platelets of 13. Which of the following should you do now? Is it okay to provide reassurance and repeat the exam and CBC in 1 week? For this patient, send a peripheral blood for flow cytometry for acute leukemia panel and obtain a bone marrow aspiration and biopsy. Start steroids or consult infectious diseases. We have Dr. Begay on the line. Thanks, Dr. Begay. So for this patient is a worrisome patient, right? Has all the signs and symptoms concerning for acute leukemia. So you can send the peripheral blood for what's called flow cytometry, and sometimes this can be diagnostic for acute leukemia. And ultimately, you're going to schedule a bone marrow aspiration and biopsy. And you want to do this before starting steroids whenever possible, unless, of course, it's absolute emergency, but this would be the ideal situation. Not appropriate to wait a week in the setting if you don't have to, right? And then consulting ID, maybe not yet, but perhaps shortly down the road, depending. Questions on that? Or I can keep going and then the first question's at the end. Yeah, okay. All right, number 3. NAIT can occur during a first pregnancy. This is true. Yes, again, this can occur during a first pregnancy, and it's mom's antibodies attacking baby's platelets, antigens. And yes, can happen in a first pregnancy as well as subsequent, and can be worse with subsequent pregnancies. And then number 4, thrombocytosis is commonly due to a primary underlying diagnosis among the pediatric and adolescent population that requires additional genetic workup and often a bone marrow evaluation. And this is typically false. Again, most of the time, these are going to be reactive cases. Yes, being aware that the primary exists, again, CML being one of the more common ones I would say we see, but in general, reactive to some underlying cause to be looking for. So with that, I thank you, and yes, happy to take questions. I saw a couple in the chat, right? Thanks for your question, Renata. The how early in pregnancy, is that asking how early, was it to treat, like to start treatment, or what was the how early? If it's how early to start treating, to be honest, I don't know that for sure. I don't know. I can look into it and get back to you. Unless there was another part of that, if that's like when to start IVIG and that kind of thing.
I think it was with the I'm trying to go back to your slides.
Because I had said you
Early
can treat
on,
antenatally moms when the NAIT it becomes a problem. Or if that was kind of the, like if you have a patient who had it, like NAIT had been a known thing, subsequent pregnancies, typically those patients would be treated with, the moms would be treated with IVIG. I don't know if that is the question.
You were
is it
talking about the testing actually when Renata put the question in. So I don't
Oh,
know,
got it.
Renata, if it was maybe about the testing when the antibody testing can be done.
no, well, no, I meant how early in the pregnancy would you start to notice that there were like, is it in the first trimester, second trimester, third trimester, when in the pregnancy? And then does it also, I had another follow-up question. Does it cause like, is it cause for abortions or like miscarriage?
Good question.
I think it
Yeah.
was, sorry.
Oh, sorry, you cut out just at the end. Sorry, you
Oh,
cut out.
storm here, so my internet's in and out.
No, that's okay. Sorry, I missed the last part though. So, um, how early in pregnancy, you said for, sorry, treatment or diagnosis?
Both. So first trimester, second trimester, third trimester, and then also like is it a frequent cause of miscarriage or like spontaneous abortion?
Thank you. So for the diagnosis piece, we've done it on patients once they're born, and it's become a question if it is NAIT, then we could recommend checking the parents for their antigen type. So the HPA, like the different platelet antigens on mom and dad, and seeing if there's any mismatch, and then checking the mom for antibodies. So I can't remember checking it antenatally for diagnostic purpose if there's a way to check baby intrauterine. There might be, and I don't really remember, to be honest, or if they're just all treated, like all subsequent pregnancies would be treated, the mom would be treated for each subsequent pregnancy once a patient has been diagnosed with NAIT, if that makes sense. Like say if the first baby has NAIT and then mom gets pregnant again, I don't know if they check all the moms all the time to see if the next pregnancy has it, or if they're just treating everyone empirically with IVIG and steroids going forward. I don't recall that, to be honest, and I apologize. In terms of spontaneous abortion rates and miscarriages, I haven't read too much about that, but the intracranial hemorrhage is like a real problem, at least postnatally. And I also don't recall like intrauterine wise reading too much about the other complications with that. Apologies. Should the mom of a patient with NA be referred to adult heme? I think it's still the OBs that would, I don't know if there's any OB people on this, but I think it's the OBs that would be the ones that would be treating, the mom. I could be wrong. I don't actually know who's treating the pregnant mom. We don't. So that's why I don't know who is the one that is doing it. That I don't know. I feel bad about that. I'm sorry. I don't have a good answer for that. For the MMR, totally agree. That's very real. We have seen patients where the only thing we can find is a recent MMR vaccine within the past 6 to 12 months that could have been associated with the development of ITP. Am I able to like get back to you guys though with the answers to some of these though? Like, do you guys have an email list or there's nothing like that?
Yeah,
Yeah.
absolutely.
Okay. Yeah.
You can just send it to us ultimately,
Okay.
and then we can forward it to the group.
Yeah. Sorry.
Absolutely. No, not at all. These are some great questions as well. Um, for the I obviously see a ton of reactive thrombocytosis that I feel like I barely give a second thought to, honestly, unless it's extremely high. Or there's, something else concerning going on on the CBC. And I don't always necessarily recommend following up, but I've also every once in a while I'll see my colleagues kind of write in their discharge summaries for the PCP to consider following, once the infection has cleared or whatever. Is it worth even repeating if we feel like we're fairly confident that we know this is reactive and that it should resolve once the inciting event has resolved?
Yeah, very good. I think if it's over 1 million, that could be cause
Mhm.
to follow up to make sure at least it's downtrending. But I think if you have like 500, 600, 700, and they have cellulitis or they had whatever, then no associated, which again typically is
Mhm.
thrombocytopenia with clots. But I think I feel comfortable without entreating the underlying cause. So I would feel okay saying it's okay to not, unless again it's that extreme
Mhm.
situation. Yeah.
Okay, that sounds good. No, and that makes sense. I mean, I think the hard thing is for us oftentimes, like you'll have these like abnormal labs that you feel like you need to comment on in your assessments, but not necessarily that you always feel like you really need to be doing anything about. So I do feel that it typically falls in that category, thankfully.
Yeah, the reactive. Yep.
Another question just popped up. What precautions should be taken at school for a child with thrombocytopenia? Oh, that's a really good question.
Yeah, very good question. So I think so part of it also will be dependent on the degree, right? So if it's like over 50, really I would say they could do pretty much whatever, but maybe maybe could avoid like contact sports like head trauma, rugby, football, soccer if they're borderline. Less than 50, I would definitely avoid the contact sports. And then same with the no NSAIDs or that kind of thing for fevers or things like that. Um, if they're severe, like less than 10 is when you can potentially have spontaneous bleeding, right? 5, much higher risk of spontaneous bleeding. Although in ITP in general, even if it's super, super low, it's exceedingly rare. Although, we say that our biggest concern is spontaneous intracranial hemorrhage, which is true. That is the most worrisome concern. But I want to say the reality is it's like, I don't know if it's 1 in 3,000 or like a very, very tiny percent would actually have that with single digit platelet counts in ITP. Now, if you have patients with cancer, right, who are still going to school and their count is 12, I would say, like more calm, quiet things. Like for phys ed, I wouldn't want them doing things that could potentially cause trauma. Um, if that's helpful. I don't know if that's helpful. Hopefully that's somewhat helpful, but
Do you ever keep kids out of school?
for no,
Especially, yeah,
yeah.
especially if they're like, I don't know,
For
like
thrombocytopenia.
early elementary school where it's still a little bit less controlled.
Yeah, I think again it would depend on the case. If there's monkey bars, I don't know if kids do that anymore, or like the jungle gyms where you're climbing on jungle gyms. I think you would just have to have a plan with the school. We try not to keep our patients out whenever possible for this because quality of life and trying to keep normalcy and things. So as best we can, we don't keep them out just for low platelet counts, typically, truly. But again, with those caveats and restrictions, or like, should you notice a nosebleed, right? Or should you notice this child is not acting like themselves, right? And then of course they have to be aware, but yeah, typically not. And truthfully, if a kid is less than 10 and has cancer, they're going to get transfused, right? And they're going to come to us most of the time. Have they ever been in single digits? I'm sure they have, but yeah.
Mhm.
Yeah.
That makes sense. I know. The uncontrolled child, always the scary thing.
Correct. Yes. And so that is another thing too. So it's yeah, that's another thing too. And it's very partly provider dependent sometimes when, what is like too uncomfortable of a setting or what is too wild of a patient, right? And like at what point do you just be like, okay, let's just do IVIG, right? Because it's easy, like it's easy enough here at least if we get it approved, right? Or steroids are easy enough, although all these things have potential side effects. But sometimes you're like not only treating patient platelet count, but you're treating yourself, you're treating the family member. And
Yeah.
so like that is a reality, right? Or they live in the middle of Molokai or, a place where it's really hard to get care. And then should they have an accident, then, so there are definitely categories where like patients may get medication treatment sooner than these patients where they live down the street and like they can easily come to our clinic, right? Or easily go to the lab and get a checkup and do a telehealth. But like we totally recognize that is not the case everywhere. And so I would say it's not wrong to do it. And yeah.
No, and I can definitely imagine on, like as you said, on neighbor islands, that it's really just so much different considerations that need to be taken into account.
Yeah.
I don't see any other questions coming through. We do have a few more minutes, so if anyone has any questions, please feel free to add them to the chat. And if not, I can give everyone an extra 5 minutes of lunch break, which I'm sure everyone will be happy about as well. Thank you so much again for joining us. Thank you so much, Dr. Hutchins. That was
Thank you guys. Yeah. And I'll
very,
look back
very
to the,
informational. I learned a lot from an inpatient setting, and I learned a lot about the outpatient aspect as well. So I'm hopeful that it was also beneficial for our outpatient providers.
thanks again for asking me to be here.
Absolutely.
Pleasure.
And yeah, if you have any anything that you want to follow up
Yes, because
for
I need
with
to
the
look
group.
and know that, and I don't know that, so I will look. But thanks for the
Perfect.
questions.
We are happy to pass along the information. Seeing some thank yous come through on the chat as well. So thank you everyone for joining us. Our next echo is, oh my God, gonna be July 1st. That is absolutely unbelievable. Dr. Jennifer King is going to be speaking about return to sports after concussion together with Jamie Higa, who is one of these psychologists. So thank you everyone for joining. We hope to see you soon. Enjoy the start of the summer. And see you in a few weeks. Thank
Thanks
you.
again.
Thank you.